So I think we kind of have two goals in this talk today. One is to give you some updates on the current state of the field in terms of theories about suicidal behavior. And then Dr. Sheftall is going to get an overview of some treatment modalities that have been developed to specifically address suicidal behavior. So the first model I'm going to talk about is the stress-diathesis model of suicidal behavior. That's developed by John Mann at Columbia University in New York. And this has probably been the preeminent research facility for studying suicidal behavior for the last 20 years. And they have this idea where, a buzzword right now is evidence-based. We're all trying to figure out ways to incorporate into practice and clinical care what the literature has shown as, real effects. So what the John Mann's group has done is they've looked at those warning signs and risk factors I showed you before and started to think about all these things are demonstrated over and over again in research as being correlated or co-occurring with suicidal behavior. So what's the relationship there? How do they all work together? Why do we keep seeing these things appear again and again? So they tried to make a model where they made a causal model out of what we have demonstrated to be risk factors for suicidal behavior. So Korins Model, there's stressors and diatheses. So stressors are not just stressful life events or things that go bad for you throughout your day. Stressors can be mental health disorders or just psychosocial life events that go on. And so stressors tend to be the things that get people into therapy in the first place and tend to be the things we focus on in therapy, right? We're going to, from the therapeutic setting, we're going to try and assess what is the psychosocial environment the kid's operating in, what are the challenges going on there, and what's the disorders that kid has, and how can we get them to move them towards health. But according to this model, that approach kind of overlooks a couple important things when it comes to suicidal behavior. And those things are that different individuals have underlying diatheses, which means vulnerabilities. So some people just may be, because of their cognitive, behavioral, and biological makeup, very resilient folks. So they might have a severe depression and a lot of psychosocial stress at school with peers, but because they have a resilient kind of system, they might not be as impacted as much by that as other kids who have a vulnerability. So the way this looks is we have stressors, again, disorders and psychosocial crises, these diatheses. So the vulnerabilities that tend to be the focus of this theoretical perspective are impulsivity and hopelessness. So hopelessness is just this idea that the future's really not going to get any better. As bad as I feel right now, there's no up from here. At best it's going to stay the same or even get worse. So that doesn't give me a lot of desire to continue on with what I'm doing. When you merge that kind of outlook on life with impulsivity, which is a desire to act. It's not a desire to just sit around and wait, but it's like I need to do something, and it's also kind of a doing something that doesn't really take into account the consequences of that action. So you have a tendency to do something that you think might make you feel better right now, not so much about what's the long-term consequences of that. According to this model, both of these processes, hopelessness and impulsivity, have a real biological basis, norepinephrine and serotonin, which is why some medications we have out there might help ameliorate their symptoms. So these two processes, stress and diatheses, how do they interact together? Stressors, like psychiatric disorder, either the new onset, which is what we usually see during adolescence, is they didn't have a disorder before and it emerges during adolescence. Or also, if there's a sudden change in the severity level of a disorder. We know some of these disorders fluctuate over time, and if there's a kind of a downturn in their functional level, that can really raise a lot of this risk according to stress. What the stressors do is it just generates an ideation or a desire for suicide, but that desire is really separated from any kind of suicidal acts as long as they don't experience these diatheses. However, if you have somebody who is fairly impulsive and hopeless, and that's occurring in the context of psychiatric disorder, it's a bad combination. And that's one of the reasons we focus on adolescents and teens, because just by nature, it's a very impulsive period of life. There's a lot of changes going on in the brain that cause adolescents to be more impulsive than they were even as children, and definitely more so than adults. So it's just an inherently vulnerable period of life to begin with, and when that's paired with psychosocial stress or psychiatric disorder, according to this model, that's what puts them at such high risk. We're going to talk a lot more about treatment later on in Dr. Sheftall's presentation, but what this model says is treat the stress, which is your typical treatment as usual. Basically, treat the depression, treat the psychiatric disorder that they have, treat the psychosocial circumstances that got them into this situation to begin with. But at the same time, what this model says is don't ignore the diathesis. There's things that we can do to address underlying impulsivity and hopelessness as well. So the treatment modality should be based on both the disorder and some of these things that can put them at elevated risk, like hopelessness and impulsivity. So whereas this model tries to make sense of a lot of the risk factors that we've demonstrated over time to be associated with suicide and put it into a causal type framework, there's another model that's really emerged just in the last 5 years, but it's just overtaken the field. You can't, when we go to meetings, the big meeting we go to is American Association of Suicidology, which is a great meeting because it has researchers, clinicians, and either people who have attempted suicide themselves or family members who've lost loved ones to suicide. So it really brings together all the stakeholders who are interested in trying to solve this problem. And this theory has really taken a predominance in the field in terms of the way people are thinking about suicidal behavior, thinking about treatment, and thinking about how to advance the field. Thomas Joyner, he's a clinical psychologist at the University of Florida, and while he was getting his clinical training, his father took his own life, and that kind of changed the direction of Dr. Joyner's career and to focus on this behavior. And from his work, he's developed this theory that suicide can be thought of as just the confluence of three processes overall: thwarted belongingness, perceived burdensomeness, and capability for suicide. So thwarted belongingness is kind of the centerpiece for him. His idea is that humans are such social beings that we have such a strong need to be affiliated with other folks, to be cared for, even to the exception of our other we typically think of our basic needs as food, water, shelter. He would say that people will forego some of those other conveniences or luxuries just to feel connected to other folks. And if you have a significant disruption to your sense of feeling belonging to someone else or needed by somebody else, that can really result in some desire to cause one's own death. There's two components to this: thwarted belongingness, loneliness, of just feeling like you're disconnected from others, but also absence of reciprocal care. And what that means is people have a need to feel like they're cared for by others, but also to give care for others. So for instance, we know like people who are married have a lower likelihood of dying by suicide. People who have pets have a lower likelihood of dying by suicide. This theory would say, well, that's because those are people that you have in your life, or animals you have in your life, that you not only can receive care from, but you give care from as well. And in the process of giving care, that's reinforcing to you through your behavior a sense of connectedness and being a part of something beyond yourself. Second process that Joyner really wants us to focus on is burdensomeness. I was talking with one of the staff before the presentation here today about how we see kids from Clarity who have, some of which have non-suicidal, so they cut themselves often, and other ones who really have a desire for their own death. And the ones that have that desire for their own death have a lot of this perceived burdensomeness where they're sensing that, my family's better off without me. All I do is cause problems for my friends, my peer group. It just sense that the absence of me would be better for the folks that I'm around than if I was here. There's a lot of shame and self-blame that goes along with this. So both of these processes get at kind of your own standing in terms of how you see yourself and how you see yourself fitting in with your social group. There's another step that's necessary for suicidal behavior to emerge, and that's acquired capability. So acquired, it means it's learned through experiences over time. And capability. So the idea of taking one's own life and acting on that is a fairly scary idea. There's just the fear of death and the unknown and everything that goes along with that to begin with. And on top of that, it's a fairly painful experience. And that alone is enough to prevent a lot of people who are very suicidal and have a lot of suicidal ideation going on from actually acting on that. So what Joyner says is risky or dangerous is when a person, through their life experiences, has increased their tolerance for physical pain or reduced their fear of death. There's a couple of ways that happens. We know that if you know somebody who's died by suicide, either a family member, a friend, or even somebody you kind of an acquaintance, as we see in schools, lots of times there's this kind of contagion effect. One person dies by suicide, and then we see a lot of this behavior popping up. This theory says, well, that's because of this exposure, my fear of death or fear of this whole process is reduced. Because of this person that's kind of abstract thing that I've never seen or experienced. But if these people that I know have experienced this and engaged in this behavior, and I know them, I judge myself to be about as competent as they are, and they were able to engage in this behavior, then maybe it's a possibility for me as well. And the pain tolerance, we know things like having a childhood history of abuse, especially physical abuse, being involved in serious motor vehicle accidents. All these things are things that can increase your risk for suicidal behavior later. This theory would say that's because you've experienced a lot of physical pain and you were able to tolerate that, and because of that, your judgment for how much pain you can tolerate and engaging in behavior is increased. You have a mindset where you can allow yourself to act to harm yourself. So how does this all work together? So if we have loneliness or we have a lack of people in our lives that we feel like care for us and we care for them, or if we feel like we're a burden to the people around us, that can result in just kind of passive suicidal ideation or feeling like, I wish I wasn't here, or life just isn't worth living. But when we have both of these together, this model would say that can generate the desire for suicide, where we actively wish we can act on this idea of taking our own life. That's still disconnected from an attempt. What we really need for this model to get from a desire for suicide to an attempt is just that acquired capability, where because we've learned how to deal with pain, or we've desensitized ourselves to the idea of death, we are able to engage in this behavior. So those are two models that are really at the forefront right now of the way we're thinking about suicide and the processes that are involved in getting to a place where people actually engage in this behavior.